Okay guys, we're going to start in with our second one. It is going to be over chapter 49. Just bear with me while I get this up and get everything set and ready for you. Okay. 49 has to do with bone disorders. The very first one that we're going to talk about some is osteoporosis. All right. Osteoporosis is a skeletal disease. It's characterized by a low bone mass and deterioration of bone tissue. It's the most common metabolic bone disease that you will see. Risk factors for osteoporosis can serve as a guide for early detection. Some individuals, though, with osteoporosis don't demonstrate known risk factors. After the age of 30, the peak bone mass is reached. Very good chart. I don't know what happened to that. Okay, a very good chart on chart 49.1 on page 1484 that goes over the risk factors for women and men both for osteoporosis. You need to know a little bit about this. Manifestations, they're often asymptomatic until later stages, and in later stages they can have a minor bump against the door facing or something that will cause a fracture, or they can sit down on the toilet too hard and cause a fracture, and that is when the doctors will diagnose them with osteoporosis. A primary osteoporosis has 3 types. You will see idiopathic, type 1 and type 2. Idiopathic, it's not very common and it's seen in children and younger adults. Type 1 and type 2 can often occur together. It has been shown to be also shown to be from prolonged use of corticosteroids, menopause, and associated with aging. Okay. You will see exaggerated spinal curvature in these. I've given you the signs and symptoms. Loss of height, like I said, pathological fractures, complications include fractures and falls. You need to be looking at the evidence-based practice on page 1491. The corticosteroids, extensive use of them can lead to osteoporosis, and these patients, excuse me, these patients will be on prolonged corticosteroid use because of rheumatoid arthritis or lupus or asthma or some other type. Secondary osteoporosis can be caused from overactive thyroid and parathyroid and adrenal glands. It causes accelerated bone remodeling. Okay. You can also see osteoporosis in patients that have chronic renal failure, that have eating disorders like anorexia or bulimia, and that have had weight loss surgeries, such as the gastric bypass. And those are all secondary osteoporosis. The main testing that they do for osteoporosis is your DEXA scan. It is a painless scan. There are no special preps for this, and no special follow-up care. You know, you don't have to have them removing metal objects. You know, you don't need to see if they're allergic to shellfish and stuff like you do CTs and MRIs. Okay, in the bone mineral density, your book does not go into the scores very well. I've given you a little list here. If they have a T, they're called T-scores. In pediatrics, you will see them referred to as Z-scores. But if they have a T-score between a plus 1 and a -1, that is a normal bone density. If their T-score is a -1 to a -2.5, they have osteopenia. And if they have a T-score that's less than 2.5, then they are definitive for osteoporosis. Medical management for osteo is preventative by nature. It should begin in childhood. Your goal is to prevent further bone loss and to maintain their independence and their ability to care for themselves. Pharmacological medications that you're going to be seeing with these patients are listed on 1486 and 1487. They're going to do pain meds, anti-inflammatories, steroids and non-steroids both. You'll see bisphosphonates and calcitonin, calcium and vitamin D supplements, and parathyroid hormones for these patients. Fosamax is one of these medications that you will see these patients teaching and are taking, and what do you need to teach them on their taking of Fosamax? Well, of course, you need to teach them to stay set up for 30 minutes to an hour after they take it, to take it on an empty stomach with a full glass of water. Okay? Non-pharmacological things that nurses will be more into on this will be diet and exercise. You need to ensure that they receive an appropriate amount of protein, calcium, vitamins C, D, K. They also need sufficient amounts of copper, manganese, and zinc to promote bone growth. You want to encourage them to do alternative therapies such as yoga and massage to help them relieve their pain and their stress levels, to reduce that stress level. Like I said, you want to focus your nursing management on education and behavior changes for these patients. You should assess and identify the risk factors from the family, like a family history of fractures, habits of diet, exercise patterns, onset of menopause in the women. It's very important that you assess their use of alcohol and tobacco and steroids and caffeine, okay? Because these all affect bone absorption and building. You need to look at their general appearance and their posture. How are they standing? Some of the nursing diagnoses are listed in your book. You need to teach them the importance of and positive benefits of exercise on their bone mass, like walking and swimming. They're very low stress activities that are very beneficial to the bone maintenance. Nutritional counseling needs to be done. They need to have a diet that's high in calcium and vitamin D. I've given you on this slide some sources of dietary calcium and dietary vitamin D. Don't be surprised if you see on your test some questions that list diets and which one would you choose for which patient. Okay? Now let's talk about osteomyelitis. I'm just running through these real quickly. I expect you to have read your chapters. Osteomyelitis is infection of the bone. It has 3 categories. It can be acute, subacute, or chronic. Acute usually happens more in the children and younger adults. The subacute and the chronic onset are more seen in the older adults. organisms that can be responsible are your Staph aureus, your Staph epididymis, E. coli, Pseudomonas, Salmonella, fungi, and microbacteria. The Staphylococcus aureus is the main one that you will be seeing. Now, this hematogenesis and the direct contact, what are the difference? Well, hematogenesis is not localized. It can spread to surrounding tissue. It's caused by an infection in a distal site, and it travels through the bloodstream. The symptoms of the osteomyelitis for this are widespread, whereas your direct is just that. It is a direct contact, and it tends to have a localized manifestation. Your direct contact would be something like those of you that had the case study where the drill bit went through the hand. That would be a direct contact. Hip surgery, any type of bone surgery can be a direct contact. These patients will present with fever and edema at the site, warmth to touch, and tenderness. As the swelling gets bigger, the joint and movement limitation will be noted. They will have fatigue and malaise, and these are very painful. With advancement of the osteomyelitis, if it's advanced and untreated, you will see subperiosteal abscesses. These abscesses will form a pocket on the bone, which will actually flake the bone off. That pus pocket will set in there, and the bones can grow weaker and weaker around it as the pocket gets bigger, and then you can have fractures. It has purulent material in it. The doctors, you need to know your labs and your diagnostics on this, which is on page 1493. The doctors will start the patient on a broad spectrum antibiotic IV until the organism is identified. Okay. The course will last from 4 to 6 weeks. They can be placed on oral antibiotics. A lot of times these patients will go home with a PICC line or a midline and have IV antibiotic therapy at home. If they do have a periosteal abscess, the doctors can go in and do an IND, especially if the bone starts necrosing. This will be done to drain that abscess and to remove the necrosed portions of the bone. They can undergo frequent debridements of this. They will have to have sterile dressings. They need to be placed in isolation. That's contact isolation. You would also need to instruct the patient that while they're in surgery that they could be having, and even afterwards up on the floor, IV antibiotics administered directly into this abscess to help fight the infection. If they have surgery to drain the abscess, like I said, they will require sterile dressing changes, and you will need to assess the circulation distal to the incision site to ensure that they have good blood flow. Your nursing management, you're going to place that patient on contact isolation. It needs to focus on rest of that extremity and immobilization of the affected area. You will administer analgesics and antipyretics and antibiotics to these patients. You need to monitor that wound and perform the dressing changes as ordered. You need to ensure that they have plenty of fluids. Make sure that they are well aware of their antibiotic regime and how important it is to complete those medications. You'll, of course, like I said before, have to teach them on how to care for catheters and PICC lines if they are going home with those, as well as dressing changes. If not the patient themselves, then family member. Now let's talk about Paget's disease. Paget's disease is a chronic disorder which causes the bone to be weak and malformed. It results in pain, deformity, fractures, and arthritis. The cause of it is unknown. It can affect parts of a bone or an entire bone or multiple bones in any one person. Most common sites that you're going to see it in is the pelvis and the tibia and the femur and the clavicle and the skull and the spine. And what you will feel, especially on the skull, when you do your physical assessment, you're supposed to be doing an assessment of the structures of the skull. The skull will be thickened. Okay? It's noted more in older patients and those that, with advanced age. It can occur in 2 stages, the vascular stage and the sclerotic stage. It results in fragile bones and frequently leads to pathological fractures. Signs and symptoms are going to include bone pain at the site, which tends to be worse at night. Edema and deformities. You'll see a lot of times these patients will have bowed arms and legs. Complications will be your pathological fractures. Now let's think about this. They've got bone deformity and they're getting pathological fractures. The bone is reabsorbing faster than it builds, so they're going to have hypercalcemia seen. Now with hypercalcemia, what else do you see? Well, you can see renal caniculi or renal stones. Excuse me. They can have spinal cord injuries, and they can possibly develop bone sarcomas. Diagnosis in your labs, you're going to see an elevated serum alkaline phosphatase, urine elevated hyperoxypurine. X-rays will be done, bone scans, and bone marrow biopsy. Okay. The elevated alkaline phosphatase and the elevated hydroxypyridine in the urine are both indicative of increased bone production. Your medical management is based on symptoms and includes calcitonin injections to regulate that calcium loss. Okay. You need to provide them with a diet that's high in protein and calcium and vitamin D. They may be given bisphosphonates as well to help bind with that calcium. Your nursing management, you're going to teach them the importance of exercise to stimulate bone growth and maintenance of flexibility in their strength. And you need to teach them to maintain a healthy weight and reduce the strain on their bones. Benign bone tumors are non-cancerous. They have normal growth of bone cells. It's seen most often in adults over 40 and children under the age of 10. They're generally not life-threatening, and they will present with few symptoms. I've given you some examples here, and they will have a slow, symmetrical growth pattern. Your signs and symptoms will be pressure in the surrounding tissue. It'd be worse at night, the pain will, and after exercise, they'll have decreased range of motion, especially as these tumors enlarge, and then the bones can fracture with the tumors. X-ray and CT scan and a radionucleotide bone scan are done, as well as MRI for diagnosis. You're going to do pain control. The doctors can do surgical incision, bone grafting, and amputation if they are bad. Your nursing management, you're going to administer analgesics, do non-pharmacological pain relief like your yoga, your exercises, hydrotherapies, that type of stuff. You want to teach them to eat high protein and vitamin diet, and you want to teach them exercise program, especially if they're having to go in for surgery before the surgery, so that can help them to maintain the strength in their limbs and prevent any contractures. Now, bone cancer and metastasis. Osteosarcoma has a greater incidence in males, and it develops in the arms, legs, and the pelvis between the ages of 10 and 30. Chondrosarcoma can present anywhere in the body where there's any cartilage. Between the ages of 20 and 75 is when it's most prevalent. It can be present in your trachea and your larynx and even in your chest wall. Ewing sarcoma occurs mainly in pediatrics and adolescents. These tumors form in the bone cavity and are present mostly in the long bones. Bone metastasis and primary bone cancer are two different processes and are treated differently. Metastasis occurs when the cells break off and travel through the lymph system or the bloodstream to the bone, and are usually observed in patients who've had a relapse. They will have, or they can be seen to have, an increased serum calcium level. 75% of these patients with bone metastasis, it is metastasized from the prostate, the breast, the kidneys, or lung cancer. And to a lesser extent from the thyroid, the colon, and melanoma. It's mostly affects the pelvis and the vertebrae, ribs, and the femur. Primary tumors are seldom seen after the age of 30. The rate of tumor growth and the response of treatment depends on the type of cancer that it is. There are 3 types of bone destruction. You can have geographic, which has well-defined edges. A moth-eaten that has less defined and it can be edges and it can be separated from the bone. And then there is the primitive, which has an unclear margins and they merge with the normal bone tissue. Osteosarcoma is the most common primary cancer, and it usually develops in the distal femur and the proximal tibia and humerus. Risk factors for osteosarcoma can be like Paget's disease, parathyroid, injections, and radiation therapy due to cancer. And on x-ray, it will have a sunburst appearance. Ewing's sarcoma presents with pain and swelling. It will also have an increased ALP level on the labs. They have fever, fatigue, anemia, and leukocytosis. The tumor has an onion skin appearance on x-ray. Your chondrosarcomas also involve the pelvis and the lower extremities and grow slowly. It has intermittent dull pain, and it has a lobular appearance on x-ray. Medical management, the objective of the medical management is to slow the growth and remove that lesion. You will see the doctors ordering chemo, surgery, and or radiation therapies, and most likely a combination of 2 or all 3. They will also receive immunotherapy and hormone therapy at times. Your nursing management primary focus is going to be on pain relief. Their pain is worse at night and it is very localized. You want to encourage them to have a high protein diet with vitamins to help promote wound healing. Okay. You want to make sure that you teach them good exercise program and promote their strength and prevent contractures, but also to prevent pathological fractures in these patients. Dressing care as needed. Strict adherence to their medical regime is important. because it's a recurrent disease, and you need to educate them on lifestyle changes and medications that are appropriate for them. Also, with changes in the body image, the nurse needs to allot enough time for these patients to express their concerns and to consult, and you may need to consult for some counseling on these patients. Now let's talk about your muscular dystrophies. There are several forms of muscular dystrophy. Some of these Ms. Enlow should have gone over with you in the pediatrics. I will go over generalized information for you on all of these. Muscular dystrophy itself is a group of genetically based myopathies. It's caused by a protein deficiency in the muscle membrane. This protein is called dystrophin. The extent of the muscular dystrophy will depend on the extent of the dystrophin that is present or absent in your patient. It is usually a progressive muscle weakening leading to the inability to control any voluntary movement. It's not just in skeletal muscle, it is also found in cardiac muscle, and the diaphragm can be affected as well. It occurs in the X gene chromosome fails to make that dystrophin. Most children affected with muscular dystrophy, of course, are males because it's X gene related, and they only have one X chromosome. If the X chromosome is not producing dystrophin, then that child is going to develop muscular dystrophy. Daughters, you will have, if you have unaffected father and an unaffected mother who is a carrier, you're going to have one daughter that will be a non-carrier, one daughter that will be a carrier. You will have one son that is unaffected and one son that is affected. Okay, and your book gives you an example of the X-linked recessive inheritance. Okay. They experience progressive weakness, leading to them being unable to control anything, like I said. Deutsch's muscular dystrophy, or DMD, is the most prevalent and has a complete absence of the dystrophin. This one, Miss Enlow should have gone over with you. Seen in children, usually the child between the ages of 2 and 6 is when it first appears. They have weakness in the trunk, and it progresses to the extremities at 3 to 5 years. You will see the Gowers maneuver used. That is where they, and your book on page 1499 has a good picture of the Gowers maneuver, figure 49-5. It's where the child will start on their hands and knees, and they will walk their way up to a standing position using their hands. They lose the ability to walk from 7 to 12 years of age, and it progressively worsens until they're usually, it's fatal in their teens to their early 20s. Their death will be due to respiratory or cardiac problems of some type. I've listed possible complications for you on the slide, like cardiomyopathy, respiratory distress, muscle atrophy and contractures, cognitive effects, and spinal anomalies, as well as your osteoporosis. Becker's muscular dystrophy, or BMD, these patients do have some dystrophin left being produced. It manifests, therefore, later in life, in their teen years and young adulthood. And when the person becomes weaker than usual, when engaging in physical activity and exercise, is when it is usually noticed. It's usually first noticed in the pelvic and the hip areas of these patients, or in the shoulders with physical exercise and activity. The severity and the progression depends on the amount of dystrophin that is there. Okay, now let's see. Medical management, their genetic link to the X chromosome, therefore it's mostly in males. Like I said before, your diagnosis is based on signs and symptoms and lab work, which you can find on page 1501. They'll show an elevated CK. They'll be hypokalemic. They will show a presence of myoglobin with rhabdomyolysis. They'll have an absence of dystrophin with the muscle biopsy, and an EMG will show a decreased electrical conduction due to that muscle damage. Medications that these patients are given are glucocorticoids to delay the progression and improve their muscle mass. Exercises should be done for these patients with passive range of motion being done at least every 4 hours while they're awake to prevent contractures and muscle tendon and shortening and atrophy. A lot of times the doctors may go in and release some of those tendons if the contractures get too severe. You need to make sure that these patients, all with muscular dystrophies, any type, maintain a reasonable body weight, because it can exacerbate or worsen their cardiac and respiratory problems. MMD is Steiner's disease. It's most common in adults. It involves the muscle wasting of the distal extremities, the hands, the forearms, the feet, the face, and the neck. You will see a delayed in relaxation phase of muscle contracture, so these people might pick something up and their grasp not be able to let go of it. Okay? Half are diagnosed by the age of 20 or later than 50. Signs and symptoms, you're going to look for those classic signs, and the classic signs of this are muscle wasting in the face, the jaw, neck, hands, feet, and the forearm. Okay? They can also present with cataracts, dysphagia, muscle wasting, adverse reactions to anesthesia could be caused because of decreased muscle tone in the diaphragm. You will see decreased peristalsis, inappropriate insulin secretion, increased carbohydrate metabolism, and excessive sleepiness. Limb girdle muscular dystrophy is a genetic disease primarily causing a protein deficit in the muscle function affecting the pelvic and the shoulder area. It has a slow progressive rate, and it's usually noted during childhood and teenage years into their adulthood. Excuse me a minute. Signs and symptoms. Nursing management is aimed at supporting the patient's independence and preventing complications and injury. You'll need to collaborate with PT and OT on these patients. Diagnostics and labs are, again, what I said earlier on page 1501. There's an abnormality on chromosome 19. Treatment is prevention of complications, support to prevent muscle wasting. Medications that you will see these patients placed on is like phenytoin, carbamazine, quinine, and procainamide, and these are listed in the box on page 1507. Excuse me. Your facioscapulohumeral disease, or FSHD, and your oculopharyngeal are what we're going to discuss next. Your FSHD is a rare type of muscular dystrophy that affects the face, the shoulders, the girdle, and the upper arms. It's more common in females than males. The diagnosis is made based on symptoms. It's diagnosed in the early 20s, and its progression is insidious. Nursing management should support the patient's independence and prevent any complications or injuries. Your oculopharyngeal is rare and generally strikes in the 50s or 60s. You're going to see these people with extremely drooped eyelids. They will be below the level of the pupil. They can have contraction in their forehead muscles, ocular muscle weakness, so their cardinal fields of gaze will be off. They'll have a weak gag reflex and dysphagia. These patients can actually live fairly well with this disease process. Doctors may refer them to have an eye lift done to help with the eye droop, or eyelid droop, excuse me. You may need to teach them how to position themselves so they can see better, how to position their head. Proper nutrition. They may need their diet modified as far as the consistency of their food goes. And they should have a good quality of life if they are taught how to just accommodate for their problems. Health promotion. For the patients with MD, you need to make sure they have a balanced diet with supplements of omega-3 fatty acids, calcium, and CoQ10s, probiotics, and glucosamine. Exercise to maintain their mobility and prevent any contractures that might happen. Now let's talk about myopathies. There are several types of myopathies. Generalized is a weakness of the limbs which can improve or worsen with exercise, and the prognosis will vary depending on the type of myopathy. Your congenital myopathies have a chromosome defect leading to an absence of muscle tone. The diagnosis is made by tissue sampling, and treatment is supportive for these patients. Your hypokalemic myopathies can be primary or secondary. It can be due to excessive renal and GI losses, diabetic ketoacidosis, or chronic diarrhea. Any condition that causes hypokalemia or any medication that causes it. It affects the proximal muscles of the legs, arms, trunk, and the neck. Medical management, of course, is your potassium replacement. It can take them within a month, is usually back to normal, and then these patients should be on a potassium supplement and a diet that is rich in potassium. And I've given you some foods here on your slide that are high in potassium. Mitochondrial myopathy, it's essentially it depletes the energy supply to the cells and the nerve cells. You'll see muscular and neurological problems in these patients. Muscle weakness, exercise intolerance, they'll have hearing loss, they can have balance and coordination problems, seizures, and learning deficiencies. Your medical management is dietary supplements with creatine and your CoQ10s to help with the production and or the use of your ATP. Steroid-induced myopathies are seen in patients that have had long-term use of high-dose steroids over a year. It causes muscle weakness and increased risk of those pathological fractures and osteoporosis. Medical management, they're going to cut, the doctor should be cutting the medication regime to change to a less frequent regime or a smaller dose. And then they should encourage a daily exercise program to promote their muscle tone. Polymytosis is an autoimmune connective tissue disorder that occurs over weeks or months. It affects the proximal muscles by destroying the muscle fibers. The cause is unknown. they think it could be triggered by some type of bacterial or viral or parasitic agents. Drugs or vaccines and stress can also, they think, may also cause this. Your signs and symptoms are listed for you. They can be systemic as well as muscular. Okay. With systemic involvement, you're going to have the dysphagia and cardiac and respiratory problems. You're going to see elevated CK levels. They're going to do muscle biopsies, and you'll see an abnormal EMG. They can have skin rash. The skin rash will be one of your confirming diagnoses. Okay? Your medical management is going to depend on the severity and the symptoms that are involved. Medications that will be given to these patients are like prednisone, immunosuppressive drugs like methotrexate. Prognosis is poor if the muscle weakness has progressed and if they are in a severe case. You need to monitor for aspiration pneumonia, dysphagia, malnutrition, and respiratory failure. You need to know the chart on page 1507 and 1508 as far as the medications go. Dermatomyositis is another autoimmune disease that affects the small blood vessels and capillaries in the muscles. It can be identified by a heliotropic bluish-purple rash and muscle weakness leading to atrophy and degeneration of the skin and the proximal muscles. Make sure that you know that they can also have an erythematous rash to the chest, face, and neck, but it's that heliotropic rash on the eyelids that is indicative. And then you will see the Gortoni, and I apologize for my misspelling. It's G-O-T. Well, I've lost it. G-O-T-T-R-O-N-I. Okay, Gortoni's rash in the finger joints. They'll have thick, cracked nail beds. Medical diagnostics. The diagnosis is done by signs and symptoms. You'll have elevated CK and eosinophil, sedimentation rate, and an ANA. See the medications on chart on page 1507 and 1508 for these patients. Okay, you're going to do prednisones, immunosuppressants. Monitor them for complications, like I said before. Okay, inclusion body or IBM myopathies is an autoimmune disorder, a progression of inflammation of the muscles. Signs and symptoms are asymmetrical muscle weakness, beginning in the wrists, the fingers, the flexors, the knees, extensors. The atrophy develops early, and it can have facial muscle involvement. You'll see an elevated CK level, and muscle biopsy will show eosinophilic and cytoplasmic inclusion bodies, and this is your main diagnostic tool. There is no known treatment, but prednisone and immune globulins improve the strength and function, but there is no sustained remission that has been demonstrated with the use of these. Your nursing management should focus on encouraging independence and patient teaching on safety and adherence to their medical regime. You need to look at the patient teaching box on page 1510. And also on these myopathies, if you will look at chart 49-4 on page 1505, it gives you each category or each type and the signs and symptoms. And this is very important for you to know. Health promotion for the myopathies, you're going to see exercise programs, good nutrition with high protein and antioxidants, supplements of omega-3 fatty acids, and CoQ10, probiotics, and glucosamine. Now let's talk about rhabdomyolysis. Rhabdomyolysis is a syndrome of muscle necrosis caused by muscle injury, which causes the muscle to release that myelin into the bloodstream. This myelin travels to the kidneys, stops at the kidney tubules, and causes kidney failure. Okay? Causes, it can be muscle compression, such as a patient that is in surgery for an extended period of time and lying in one position, those that are comatose, extreme physical exertion in athletes. I know you've probably heard the expression that they've blown out their muscle. Well, this is basically what they're talking about. Snake bites and toxins and viral and bacterial and fungal infections. Also, any type of blunt trauma. I've taken care of a couple of patients in the hospital, and my students have taken care of a couple just recently that have had rhabdomyolysis because of compartment syndrome. That's where they get hit very hard in one muscle and it causes the muscle to atrophy. Okay, and to release the myelin. Signs and symptoms, you're going to see muscle pain, fatigue, fever, nausea and vomiting. They're going to have dark colored urine because of myoglobin that is being released. Diagnosis is based on an elevated CK level and myoglobinuremia. Look at your lab boxes on page 1501 again. Complications, you're going to see acute renal failure, hyperkalemia, hypocalcemia, hyperuremia, metabolic acidosis, and compartment syndrome in these patients. Medical management, they need to identify and treat the underlying cause, be it snake bite, infection, whatever it is. Increase the fluids to hydrate that patient and prevent obstruction of the renal filtration. Your nursing management, monitoring the kidney function is very key, and it must be closely monitored. A lot of times these patients will be admitted to ICU for strict monitoring and hydration. You need to monitor those fluids and electrolytes both in their lab work, and be prepared to give these patients some bicarb IV that helps prevent that myoglobin breakdown in the kidneys. Eaton-Lambert syndrome is an autoimmune disease associated a disease that affects muscle activity and function. It is associated with small cell carcinoma of the lung. It's caused by a decrease in the acetylcholine release and circulating immunoglobulin antibodies that block the calcium channels. I've given you the signs and symptoms of it here. Diagnoses may be done with electrophysiological response to nerve stimulation. In other words, they're going to do a nerve conduction study. They'll have elevated antibodies to voltage-gated P and Q calcium channels, especially if the case results from lung cancer. Okay, your medical management. Patients with lung cancer must be closely monitored for muscle weakness. Drugs given that increase the acetylcholine release, like prednisone and immunoglobulins. You need to know that chart on page 1507. Your nursing management, you're going to teach these patients safety measures and to adhere to that medical regime. And symptomatic care is what you're going to be giving to these patients. Okay, polio. Poliomyelitis is caused by a viral infection spread through the orthopharyngeal or fecal matter. They can demonstrate difficulty breathing and flaccid paralysis of the legs. It depends on the severity of the disease process. Some of them that may just have mild symptoms, and some may have severe. Incubation can be from 7 to 21 day period. Third world countries are still struggling with polio. Your signs and symptoms I have listed here for you. Medical management, the biggest way to manage polio is prevention. It's the best treatment. So immunization with either an IPV or an OPV, which Ms. Candler has gone over with you. Just a refresher, your vaccine schedule for children is 2, 4, 6, and 18 months, and a booster at 4 to 6 years. Adults, the only adults that need to be immunized against polio are those that are planning to travel in polio-active countries, those that work with polio virus, or those that are caring for patients that have polio. Your treatment is supportive with analgesics. You want moist heat application, bed rest in the acute phase, followed by extensive PT therapy, and use of extensive devices like braces might be needed for these patients. Now that we've talked about polio, let's talk about post-polio syndrome. It can happen to patients that have had polio, usually greater incidence in those that have had polio during their teenage or adulthood. And what happens is the nerve connections that grow back after the insult of the polio are weaker, and as you get older, these very tenuous connections in the nerves break down, causing renewed weakness. You have signs and symptoms will be new muscle weakness, fatigue, muscle and joint pain, dysphagia, respiratory difficulties, and decreased ability to tolerate cold. Okay? Best treatment is prevention of polio to begin with. On the post-polio syndrome, the goal is to continue an active lifestyle as much as possible and control their pain with analgesics, heat and cold, and a balanced diet. You need to focus as a nurse on supportive care. Encourage them to be vaccinated if they plan on traveling. Educate or evaluate existing conditions like arthritis surgery that can reduce their mobility and cause difficulty in them doing the exercise program. And you want to develop and encourage an active exercise program with these patients, and they need to complete range of motion exercises to all joints at least 4 times a day, and you need to ensure that they have frequent rest periods and that they take them after they continue home. You want to administer analgesics and warm and cold compresses to promote comfort. Warm compresses to prevent the muscle spasms, cold compresses to decrease the inflammation. You want to educate them regarding mobility aids and to monitor for safety. Muscle cramps is our next topic that the book goes into. Of course, muscle cramps is a nerve malfunction. It can be caused by dehydration, lack of minerals, and imbalance of electrolytes, overuse and strain of muscles. You can have idiopathic muscle cramps, which you will see in middle-aged to older adults. This usually occur during night. It usually affects mostly the feet and the calves. It can be indicative of underlying diseases such as spinal nerve irritation or compression, thyroid disease, and liver disease. Your medical management, you want to treat prophylactically, including stretching exercises before, of course, they exercise, but also stretching exercises prior to going to bed. A balanced nutrition and fluid intake. Your nursing education is going to focus on safety and prevention. Okay. Fibromyalgia is exact cause is unknown. It is a chronic musculoskeletal pain. These patients have elevated growth hormone levels and substance P in the spinal fluid and low serotonin levels. They're sensitive to minor pain. It can coexist with diseases like lupus and arthritis. Classification includes widespread pain for a minimum of 3 months and pain at 11 or 18 tender points on palpation. The points are at the occipital, the lower cervical, the trapezius, the supraspinatus areas, the ribs, the epicondyle, the gluteal, and the knee. Excuse me. Clinical manifestations and diagnosis, your signs and symptoms I've listed here for you. The onset of symptoms can be associated with stress, trauma, or infection. They can be aggravated by poor posture, strenuous exercise, and smoking. It's based on your diagnosis is based on subjective symptoms. Your medical management is based on the pain level, stress level, and the overall health of the patient. There is no cure. Treatment can help alleviate symptoms and restore their function. These patients need education and stress reduction, physical exercise, and medications to reduce pain, and to improve their sleep quality. Pregabalin is approved for fibromyalgia now. Anxiety and depression need to be controlled in order to control the flares of the fibromyalgia. Your nursing management, you're going to focus on assisting the participation in regimes to minimize their discomfort and deal with current stressors. Massage therapy, relaxation techniques, and they also have benefits from TENS units. Okay, and that's the end of our second one. Thank you very much.